Hi there, my name's Jack and welcome to my new channel, All About Medicine. Today we're going to be discussing the anatomy and the physiology of the fetal circulation, and we're also going to move on to talk about some congenital heart defects and the chromosomal disorders related to them. Now, when we're talking about fetal circulation, there's three important structures that we need to talk about. So the first one of those is the foramen ovale, which is the hole in between the right and left atrium. The second one of those is the ductus venosus, which is the vessel that connects the incoming umbilical vein into the inferior vena cava. And the third one of those is the ductus arteriosus, which connects the pulmonary artery into the arch of the aorta. Okay, so now let's talk about how those different structures fit into the fetal circulation. So first of all, we have oxygenated blood coming from the mother through the placenta up the umbilical vein, and which eventually bifurcates, and that goes off into the portal vein and the ductus venosus, which we mentioned earlier, which carries the oxygenated blood into the inferior vena cava where it's needed. This then takes it up to the heart, where it enters the right atrium. And once it gets to the right atrium, it mixes with some deoxygenated blood from the superior vena cava. So now we need to talk about what's happening to the lungs during this time. So the lungs, while the fetus is in the womb, are filled with fluid. Now, because this fluid is in the alveoli, the arterioles surrounding those alveoli are constricted. Now, because all these arterioles are completely constricted all over the lungs, there's millions and millions of them, it builds up a huge resistance against blood flow trying to get into the lung. So because there's this high pressure in the lungs, we can trace this back through the blood vessels. So if there's a high pressure in the lungs, then we can assume going down the pulmonary artery there's a high pressure there. The right ventricle must therefore have a high pressure, and therefore the right atrium must also have a high pressure. Now this is where the idea that the right atrium has a higher pressure than the left atrium in fetal circulation comes from. And this is why the foramen ovale remains patent while the fetus is in utero. So this means that blood from the right atrium can cross into the left atrium, be pumped up through the left ventricle up into the aorta and perfuse the developing fetus. Now it's time to mention the final structure which we talked about, called the ductus arteriosus. Now, blood that's travelling into the right atrium and manages to get into the right ventricle, which a fair amount will, travels up the pulmonary artery. Now this is where the ductus arteriosus connects the pulmonary artery into the arch of the aorta. This means that most of the blood travelling up through the pulmonary artery, because of the high pressures in those pulmonary arteries heading to the lungs, can travel up through the ductus arteriosus and get into the arch of the aorta and move back around the body. So now, once we've got through this quite complicated system in the heart, the blood can perfuse the rest of the body and it can return to the mother for reoxygenation. So it does this by coming down the descending aorta, and where the descending aorta bifurcates into the iliacs and the internal iliacs, the umbilical arteries plug in and pull that deoxygenated blood off the placenta. Now the reason blood travels down these instead of going down into the legs and back up again is because there's a very low pressure in the placenta, which means that blood's preference will be to go down those umbilical veins and return to the placenta and therefore into the mother. Okay, so now we're going to discuss what happens as soon as the baby is born. Now first of all, we just need to talk about the important changes that happen first. So the baby needs to take its first breath, so that's when you hear it crying or coughing, spluttering. That's important to hear at birth, and this is because, as we talked about earlier, the baby's lungs are full of fluid. Now when it takes that first breath, it begins to push that fluid out into circulation and air begins to fill the alveoli. Now this is incredibly important because, you know, when we talked about earlier, these arterioles are all constricted. Well, now they can sense that the air's in the alveoli and they dilate, which reduces the resistance in the lungs, allows blood to start flowing in, and then the blood can grab oxygen from the lungs and take it around the rest of the body as we're used to in an adult body. The other thing that needs to happen is the vessels in the umbilical cord need to be closed down, so the blood coming from the mother needs to be stopped. Now so as soon as this happens, it means resistance can build up there, and it means the changes that need to happen to the fetal circulation to let it live in the ordinary outside world can begin to happen. Nowadays, these can be cut off by a couple of means. So we can either clamp it with a surgical clamp, so a man-made device, or Mother Nature has quite a nifty way of doing it. So the grey sort of white stuff that makes up the umbilical cord that you can see surrounding the umbilical vessels at birth, that's called Wharton's jelly. Now this jelly, as it's called, in the womb is nice and warm and it's soft, and the blood vessels travelling through it are completely dilated and blood can travel through. But because we need to stop that, when this jelly hits the outside cold air, it reacts to the temperature, it begins to tighten and constrict down, blocking off those vessels. And so this is, if anyone ever cut through an umbilical cord, they will have noticed it's quite tough. That's because this stuff really sort of hardens, so no blood flow can get through. So now that the vessels in the umbilical cord have been clamped off, the ductus venosus and the rest of the umbilical vein are just going to have blood in stasis in them, so that's just going to clot. So now the ductus venosus and the umbilical vein have sealed off. They now form the ligamentum venosum. So the blood in them has just stopped, and this is all clotted, and so now it forms into this structure. So this now means the deoxygenated blood flowing up through the inferior vena cava is not going to be oxygenated with any blood coming up through the ductus venosus. So when it comes up into the heart, the right atrium is just going to be filled with deoxygenated blood. Now we also talked about the pressure now dropping in the lungs. So blood is gushing into the lungs, being oxygenated and being carried back into the left atrium. Now because of this, the left atrium is going to be at a lot higher pressure than the right atrium. And so now this foramen ovale that was so important before is going to close off like a valve, and no more blood is going to transfer through there. And this happens within the first few minutes of life. So now this means that oxygenated blood is going to flow from the lungs, and it's going to travel into the left atrium, into the left ventricle, and be pumped up into the rest of the body via the aorta, as we know it to happen in a body after birth. So the last structure or adaptation of fetal circulation is the ductus arteriosus. Now this can't remain open because it connects the deoxygenated blood with the oxygenated blood, so this has to close. Now as we know, the aorta will now have a higher pressure than the pulmonary artery, and so blood would naturally flow in that direction through the ductus arteriosus, but we don't want this to happen, so it has quite a clever way of closing off. The first thing it does is it detects the oxygenated blood trying to flow through it, and this causes it to constrict down, so it begins to close off. The other thing that happens is that during gestation, the placenta will have been producing prostaglandins, which keep the ductus arteriosus dilated. Now that the placenta is gone and there's no prostaglandins, it will begin to close off and constrict. So after the first few days of life, this ductus arteriosus will have closed off, and it would have become the ligamentum arteriosum. Now this fact that it closes off a few days after birth is quite important when we come to talk about congenital heart defects later, so remember that point. So we haven't talked about the umbilical arteries yet that connect down in the internal iliacs. So now we have oxygenated blood coming down the descending aorta and travelling via that route into the internal iliacs. Now, because these umbilical arteries have now clamped off, the blood has built up in them and clotted, the resistance is high in them, and so blood's not going to want to flow down those umbilical arteries. These eventually close off and become the middle umbilical ligaments. So now let's look at things that can go wrong with this system. So these can be broadly classified into cyanotic and non-cyanotic conditions. So first of all, let's look through the non-cyanotic conditions. So the first one on this list will be a ventricular septal defect. So this is where there's a hole in between the two ventricles and the septum has failed to form correctly. Now this is an important one because it's present in about 50% of congenital heart diseases. It's associated with trisomies, so Edwards, Vitale's, Downs, and it's also associated with Turner's. Your presentation of this might be no symptoms at all, it might be quite mild. However, if it might be more moderate or severe. So you might see things like a failure to thrive, or they might be have poor exercise tolerance, or feeding is about the only exercise they can actually do. So your medical management, you're going to be looking at heart failure drugs, so ACE inhibitors, diuretics, digoxin. However, in the end, you're going to want to surgically manage these patients, so it's a pretty simple concept. You just want to plug the hole that's causing the problem, so you put a patch in between the two ventricles and complete the septum, and that stops the problem. The next most common one is an atrial septal defect, and so this is when you essentially have a patent foramen ovale, so it fails to close. Symptoms are usually very rare with this. However, if you do get them in an adult use, you notice things like shortness of breath, fatigue, or palpitations. It's heavily associated with Holt-Oram syndrome and Noonan syndrome. So any of the chromosomal disorders that I talk about today, I'm going to pop links to in the description below if you want to go find out more about them. And so for this, if it's a problem that's been discovered, you're going to be looking at surgical closure about 4 to 5 years of age, is what's currently recommended. The third one I want to talk about is patent ductus arteriosus. So this is where the ductus arteriosus just fails to close after birth. And this will be present in about 5 to 10% of congenital heart defects. It's associated with Holt-Oram's, a rubella infection during pregnancy, or Down syndrome. Symptoms again tend to be quite rare, however you might notice a failure to thrive or recurrent lower respiratory tract infections. There's also a murmur that's described as machinery sounding that can be heard at the upper left sternal border. So medical management of this problem will be heart failure drugs again, so we're looking at diuretics, and surgical management, so you're going to want it closed. If they're symptomatic, then you want to close it before the first year. However, if they're non-symptomatic, then you want to close it at about year 1. So the next most common is pulmonic stenosis. So this is where you get stenosis of the pulmonary valve, meaning the blood flow to the lungs isn't quite as good. So this is present again in about 5 to 10% of congenital heartbeat defects. It's associated with all the ones we've talked about so far, so VSD, ASD, PDA. It's also associated with tetralogy of Fallot, which we'll get to later, and as well as this rubella infection and Noonan's. Just as a side note, it's worth knowing the torch screen for infants. So this is a test for the most common vertically transmitted infections. So the top one being toxoplasmosis, O standing for other, because there are some others, R standing for rubella, C for cytomegalovirus, and H for herpes simplex virus. And these are all ones that can be transmitted from mother to baby and may cause problems at birth. So again, they can be asymptomatic again, but you might notice a failure to thrive or shortness of breath. However, when they're born, this can cause a lot of problems, and so management at birth of this might be resuscitation. And this also goes back to what we were talking about earlier, so you might want to give them a prostaglandin infusion. Now this is to keep the ductus arteriosus patent, because we want blood flowing in from the aorta to the pulmonary artery so the lungs can continue being perfused, because we haven't got that blood coming up through the pulmonary valve because of the stenosis. Surgical treatment for this problem is going to be balloon valvotomy, so essentially stick a balloon in there, inflate it, and open the valve to try and resume some normal blood flow through into the lungs. So the last ones of the non-cyanotic conditions that I want to talk about is coarctation of the aorta. So this is essentially where you have at the end of the aortic arch, you have a constriction, a small constriction of the aorta there, and so obviously you can imagine that might result in problems. It's incredibly rare. It's associated with a bicuspid aortic valve, VSD, and also Turner's. It's rarely symptomatic, but if it's severe, then you can have failure to thrive again. You can also have an increase in respiratory rate and general sort of lethargy. Treatment for this problem is going to be in the form of either surgical correction or otherwise similar to the thing we talked about earlier, so a balloon angioplasty. So stick a balloon in there, inflate it, and it'll open up the artery. So now we're going to move on to talking about the cyanotic condition. I'm only going to talk about the two most common today. So this is tetralogy of Fallot and transposition of the great arteries. So we're going to start by talking about the tetralogy of Fallot. Now, this is the most common cause of blue baby syndrome. It happens when you have 4 different defects, so tetra meaning 4. So you have A, what we were talking about earlier, pulmonary stenosis. B, you have an overriding aorta, which is an aorta that comes down and then sits over the top of a C, ventricular septal defect. And then you also have right ventricular hypertrophy. So there's quite a lot going on here. It's heavily associated with a deletion on the 22q11 gene, which I don't expect anyone to remember, but that's DeGeorge syndrome, and it's also associated with Down syndrome. Most cases in the UK are now recognised, so you can stop the baby becoming cyanotic, and this is called pink fallow because obviously the baby's well perfused. However, it's mainly characterised by severe cyanosis at birth and also a low birth weight. As you might expect, you will want to give oxygen to this infant because it's clearly not getting enough, and as we talked about earlier, you're going to want to keep the ductus arteriosus patent, so you can compensate for some of the defects, and so you want to give them an infusion of prostaglandin. Further treatment for these children is going to be surgery, which you want to give them in the first year of life, and sometimes this surgery may be palliative as well, as the prognosis is very poor. Okay, so the last cyanotic heart condition I want to talk about is transposition of the great arteries. So this is where the pulmonary artery and the aorta essentially switch places. So the aorta is going into the right ventricle and the pulmonary artery is sitting into the left ventricle. So this again is one of the most common cyanotic heart conditions you can have at birth, and it's generally associated with maternal risk factors, so rubella infection, alcoholism during pregnancy, an age of 40 plus, or diabetes during pregnancy. This again will present at birth with cyanosis. However, it's important to remember that if you have a ventricular septal defect or a patent ductus arteriosus, you're going to get a compensatory mechanism happening where oxygenated blood can flow into the right area through one of these holes. So days later, when the patent ductus arteriosus closes, your baby might suddenly become cyanotic at home. What we want to do for these children is we need to give them prostaglandin, so we want to keep that ductus arteriosus patent. We can also insert a balloon in between the left and the right atrium to keep the foramen ovale open, creating that compensatory mechanism and mixing the oxygenated blood into the right place. However, eventually they're going to need to get surgery in the form of an arterial switch operation, which is self-explanatory really, but it's basically when you get the aorta, you plug that onto the left ventricle, take the pulmonary artery and plug that onto the right ventricle where they should be. Okay, so that's all the congenital heart defects that I really want to talk about today, because otherwise it goes on too long. I've included a link in the description to a full list of them if you want to go and look at any more. There's also links to the chromosomal disorders that can happen and some of my other references. If you like what you saw today and want to see more of it, then you can also hit subscribe. Thank you very much.